Hello, everyone. This is Dean McElwain, the President and Chief Operating Officer of Castle Conley Private Health Partners. Thank you for joining us this evening. Speaking to you from the home office up in Bridgeton, Maine. And we're really thankful that you've taken the time to communicate with us and check in, and hopefully we'll be able to share some good information with you this evening. And without further ado, so we can jump right into the content, I want to introduce Marissa Montecalvo. She's a professor of medicine, Division of Infectious Disease, Department of Medicine at New York Medical College, and Health Services at New York Medical College, and serves as Deputy Commissioner of the Westchester County Department of Health. She has also served as hospital epidemiologist at Westchester Medical Center. Welcome, Dr. Montecalvo. Thank you so much for joining us this evening, and your willingness to help inform our members, our guests, our physicians, etc. So please feel free to begin, and then we'll go for about 15 minutes that we will work through together. Please feel free to start.
Thank you. It's a pleasure to be with you. Would you like to begin with questions, or how would the group like to begin?
I think what we will do is have you just go through your presentation, and then I will ask you some questions. If you want to give an overview, the content for the questions that we're going to try to focus on, and I know you have a prepared presentation, really to kind of walk through the basics of how contagious, how deadly, the isolation necessity compared to flu. Do people develop immunity? Testing, who, where, how, when? How should I deal with my ongoing health concerns? And maybe work through some of the myths versus facts. And then any updates that you have in real time will be helpful. But I think if you want to walk through your prepared presentation, and then we can kind of go into the Q&A section of it, would be fine.
Sure. So the presentation that is posted here is more lengthy than the time allows for. So let me, I'm going to go quickly through the biology, a little bit about diagnosis, the epidemiology, clinical presentations, and I think we want to open it up to questions. But I just want to say that when we think about the COVID-19, the new coronavirus that we are now struggling with, we always look back to SARS, which was the first novel coronavirus that occurred in 2002 and was contained by 2003. It had about 8,000 cases. The death rate was approximately 10%. It infected multiple tissues. But if you look at the second part of this slide, what was remarkable during SARS was that people really didn't peak with virus inside them until approximately day 10. And so people were not that contagious because they were, by the time the virus peaked, they were already sick, and so they were being taken care of. And therefore, there was not as much transmission as what we're seeing now. Virus was detected after symptoms, which was actually most unusual for a viral infectious disease. But you could shed virus for some time, and there was hospital transmission and situations where they thought that there was super spread, as is depicted in this air shaft in a hotel from Vietnam. So this, of course, is Wuhan after it was closed down. And of course, we've all been very concerned. This is a news feed just from January 31st, when there were 7,000 cases in China. And I think this is a slide that we want to spend a little bit of time on. So when you look at infectious diseases, you want to know about whether or not there's a high mortality rate associated with it, and that's what you see here on the y-axis. And on the x-axis, what you see here is called an R factor. What an R factor is that for every single case that one has of an infectious disease, how many more people will become infected. So, for example, for seasonal flu, it's just over 1, meaning that for every single case, there's 1 more that gets infected. You would like your R value to be less than 1. That is, every case doesn't result in another infection. And seasonal flu has a mortality of approximately 0.1%. Okay, these are various infectious diseases that we've struggled with over time. And measles being the most infectious with an R value of 15. 15 people get infected for every 1. And then if you look at mortality, avian flu having some of the highest mortality, and Ebola. So what about the new coronavirus? Well, it's sitting here in the rectangle, okay? So it is estimated that the fatality rate is probably about 3%, although until we know the outcome of all those people that have become infected, we don't know that for sure. But this is very important. The transmission is well over 1. It's somewhere between 2 and 4. And now I'm going to just try to explain to you why that is. Why is there so much transmission? So this is just a graph from China. This is showing you over time the number of cases and all the interventions that were done. There we have the U.S. citizens coming back. We have the first U.S. case in January. We have airport surveillance in the United States beginning in early February. And then we have the issue of passengers on the Diamond Princess. 1 passenger is infected, and that eventually leads to several hundred passengers being infected in a closed setting. And I'm just going to take you through the timeline most recently over the last 6 weeks. So if you go back to the beginning of February, there were 11,000 cases in China that were confirmed. And at that point in the United States, we were placing persons from Wuhan or from the Hubei province on quarantine. Then you have the Diamond Princess comes in with an infected passenger, is not allowed to come into port. There's another ship, the Westerdam, arrives in Cambodia, and after everyone is off, a case is identified. And by mid-February, when the Diamond Princess was finally allowed to let passengers off, there were 355 positives, with 36 of those being Americans. Italy got started here, South Korea, Iran, U.S. community transmission, and here we are yesterday. And you can see the slowing of the increase in China over time. So you can get all of this from the World Health Organization Daily Situation Reports, which is a wonderful resource. Italy has been particularly problematic, but I'm going to try to explain to you now a bit of why are we seeing so much of it. Well, it looks as though when they looked very carefully in China at people who had worked at the seafood market, where we believe there's the intermediate host where this virus probably first began to replicate and then was able to spread to humans, and that host is not known yet. Interviewing people who first presented with the atypical pneumonia at the seafood market, we could see that the incubation period had a peak here of about 5 days and could go out to 14 days, and thus the quarantine of 14 days. Now I'm going to just go through quickly and show you something about virus. So if you look at when we can detect virus, these are days since onset of symptoms, you are detecting virus in nasal swabs. These are 17 patients that are graphed very early on. And this is different from what we saw with SARS. With SARS, the peak virus was here. With this novel coronavirus, with COVID-19, your peak virus is very early on. And so this is spreading much more like influenza, and that's why we're seeing the number of cases that we're seeing. So I can go into various aspects of this, of clinical presentations and personal protective equipment, as well as treatment and prevention. But since I don't know who's on the call, perhaps this might be a moment to pause and see what questions there are.
Yeah, I think it's a mix of our physicians as well as members. So it's sort of a blended presentation, if you will. I think approaching it from first from the member, patient's perspective, and thinking about what type of questions they might have, thinking
Sure.
about information that would be useful for them. And that's, I think kind of focused in on, we had a lot of questions come in about how folks should deal with their ongoing health concerns. Should they go to see their doctor? Should they stay at home? Obviously, we want to disseminate the correct information around that. And then you've done a good job in the beginning here, kind of talking about it, comparison in some ways to flu and to other viral diseases. I think it's important to reiterate, some of those dynamics for patients as well, so they understand that. So maybe the first part of the next 5 to 7 minutes, we will focus on important information for patients to have, and then we will focus in on the clinicians' questions after that, which really, in many ways, talk about treatment and also about managing testing, making decisions around testing, the types of protocols, and then, of course, protection for healthcare workers is also an important part of the questions.
Surely. So with respect to patients and what you should do, I'd like to take you to the CDC website. So this is actually looking at just cases in the United States, but if we start at the beginning, the CDC website is truly a wonderful resource, and I would encourage everyone to spend some time at this website. So this will explain symptoms, what to do about persons who are at high risk, what about pregnancy. It will give you various advice in many areas. And I think one of the questions, and I know I saw this question submitted, is, what do I do in terms of my regular medical appointments? So during this acute period where the United States is very aggressively moving toward complete social containment and avoiding exposure to groups, many medical practices have actually gone to telemedicine or just making telephone calls. Not everyone has the capacity for telemedicine by any means. So just as there are reduced numbers of persons in the workforce working from their regular job in all areas of our society, that is the same in outpatient medicine. But it is very important that those who truly need care seek that care. So, for example, if you need to have a staging diagnostic test for cancer, or something that is really a point of decision making in your care, you should, of course, discuss it with your physician. But just because of the containment is not a reason to automatically not do the test. So important medical care should be pursued. The last thing anyone wants is for people to be getting sick because they didn't get appropriate care. There are many things that we do in medicine that are routine, and so some of those things can be delayed can be dealt with without face-to-face contact. And those kinds of appointments can certainly be reduced. But to the extent that there are outpatient visits that are decision-making points for how your care for whatever illness you have will be monitored, you discuss it with your physician, but there's no recommendation to say that you should not go to those appointments.
Maybe I can ask a few specific questions that are coming in on the Q&A section, so that will be helpful, I think, as well. And getting one specific question, should we take packages or not at home? Is there a risk of being, transmission from packages or getting the mail? Any evidence
Right.
of that at this point?
Yeah, so I think, and I don't think there's evidence of that, but I think there's a piece of information that needs to be said about that. So you've all heard about the importance of hand hygiene and really being very careful about what you're doing, what you're touching, and disinfecting your hands on a regular basis. And that's a great example of why hand hygiene is important. I don't think you need to wipe down the package. When Amazon delivers something to your house, I think you can still open the box, and you might say to yourself, well, what if the person in the delivery truck was positive and doesn't know it, right? But the key thing here is to be regularly disinfecting your hands. You don't know what organisms are where. And so, you can open the package, you disinfect your hands. That should break the cycle of getting any what we call transient flora or transient organisms onto your hands. The problem when things get onto your hands is that your hands often are near your mouth, and they're frequently near your eyes. And those are ways in which we self-inoculate. And you may think that you don't put your hands by your mouth very often, but many of us actually do. And so I think being scrupulous about hand hygiene, carry alcohol hand sanitizer with you, and really be careful about that. When you're turning that doorknob, after you go in, when a public doorknob, then you disinfect your hands.
That's a great answer. Thank you very much. And the reason I sort of chuckled was thinking back to when we had the anthrax threat after 9/11 and how unsettling that was as well.
Yeah. Well, anthrax, I want to comment on that. Anthrax was an extremely unusual situation because there you had an organism that had what's called a spore stage, so it was easy for it to survive through the mail. One of the things that you have to remember with novel coronavirus is that these are viruses that are very susceptible to hand hygiene. These are enveloped viruses, and the reason that's important is because when a virus is enveloped, actually detergents and things that we use to wash our hands are very good at disrupting that virus.
Well, that's great to know. I think that's really helpful. A couple of other questions. Should we wash our faces too or not? Is that something that's helpful?
Well, you should wash your hands before you wash your face, but I think you should wash them both in that order, hands and then face.
Okay. Other questions, things like going to the dentist, or there was another question about someone in their 60s was asking, should they go to CVS and get a pneumonia shot, or not go to CVS was the exact question. What do you think about that?
Well, so I just want to back this up a minute and say that if you have not had a flu shot, you still need to get a flu shot. Even though we're starting to see fewer cases of influenza, at least in New York at this point, it is very important to receive the vaccines that you need, because it'll be very important to help distinguish what you may have. And so we really want to be sure that people really think about their vaccines and use this time that we're in as an opportunity to really, if they haven't been vaccinated, to talk with their primary care provider and see about, what would be the best time to get that done. Should you go to CVS to receive a vaccine, I would say yes. If a vaccine is indicated for you at your age and for whatever reason you never received it, this is the time to take better care of your health.
Okay. Another question was, we've been told the symptoms of fever, coughing, difficulty in breathing. Are these always the symptoms? Are there others? Can they be milder?
Okay, I will go back to my slides a moment if I can figure out how to do that. Let's see. It's always tricky when you put in these little, let's see, I'm on CDC. Oh, here we go, sorry. Let's go back to, let me just scroll down a minute, and let's go over some symptoms. Okay, so
and by the way, everyone on the webinar here, we've got a lot of questions. I don't think we're going to get through all of them, of course. We will do our best after the webinar to try to answer some of them. So if you've been a participant, stay tuned and we'll try to get back to them, and certainly over the next few days, try to answer as many as we can. We appreciate them for sure. Thank you.
So this is reviewing a study of hospitalized patients from China. Now, these are all patients who are sick enough to have pneumonia. And but I want to point out to you that the symptoms of fever and cough are almost always there, fever especially, cough 75% of the time, muscle aches and feeling tired about 44% of the time, actually bringing up sputum about a third, and diarrhea, although coronaviruses get into the GI tract, not that common to have diarrhea. This is just a medical term, lymphopenia, which is quite common. So what happens is, if you look at this time frame, so people don't feel well. We begin with the onset of symptoms, and it is the shortness of breath that usually gets someone into the hospital. It's the fever, cough with shortness of breath. The people who develop shortness of breath can very quickly go on to get very, very sick. And you can see here the different parameters. This is a respiratory distress syndrome and needing the intensive care unit. However, if you look at the first 44,000 cases reported from China, 81% were very mild. Okay, so you don't have that rapid progression, but there are some severe cases, more commonly in people who have other conditions like diabetes, lung disease, heart disease, and in the elderly.
Okay. And then a little local question for you for just a minute or so, quick answer. How are things going in Westchester? One of our patients actually asked.
Oh, yeah, well, we're busy. So Westchester was a unique situation, I think, relatively unique, although I'm sure it's happening all over, which is that, we had a very tight community. The case that, was the first identified case, one never knows if it's the first case, was, as you might have read in the paper, was a member of a synagogue. This is an area where people spend a lot of time together. And then, of course, there are social events like bar mitzvahs and bat mitzvahs. And so there was a very large group of people under quarantine.
Thank you. And so I want to move into the physician section, try to answer some of the questions for our docs here
sure.
on the line. One of our docs writes, we as primary care practitioners are at a conundrum. Some are staying home in self-quarantine, and others are going in for sick patients with non-respiratory issues. Exactly what would be your recommendations?
So I'm going to move over to the personal protective equipment slide. So you've all seen these slides, right? I mean, you know, you've all seen these pictures. I'm a big reader of the New York Times, but wherever you are, I'm sure you're seeing these pictures. And we started out with full gear, right? N95 respirators, eye protection, gowns, and gloves. And over time, as we're understanding transmission better, it's clear that certainly for general medical care, in someone who you think who is a COVID-19 case or who you think could be a COVID-19 case, you could be using just a surgical face mask. A gown is a good idea because it does stay in the environment, and gloves, so it's contact and droplet precautions. I personally feel, in answer to your question, that I would continue to see patients. I am continuing to see patients. I think that personal protective equipment works, and I think that the times when healthcare workers become infected, it's usually because of an unanticipated exposure, and so really trying to be very careful about how patients come in and having patients self-identify if they have fever and cough before they come in so that they can be placed in an appropriate room. There can be appropriate personal protective equipment, I think helps to break that potential cycle of having a healthcare worker get infected.
Has the guidance changed on use of gloves or masks at all, or is that CDC guidance still the same in terms of?
So the guidance has changed on the, so the gloves are still in, and gowns are still in. And the reason for that is just because of the environmental contamination. When you're close to the person, you don't want to get it on your clothes, and then it can survive for a bit, and then you touch your clothes, right? You take your iPhone out of your pocket, you know, all of that. It's easy for you to self-contaminate. But the mask has changed. So at the beginning, based upon the SARS experience and knowing that we were dealing with an unknown organism and it wasn't clear how it was going to spread, the most conservative measures were used, which was an N95 respirator with eye protection. That has been adjusted to be a surgical face mask. Many people still use eye protection, and it's not a bad idea because it's very easy to touch your eyes before you have a chance to disinfect your hands. Get those gloves off, get the gown off, and disinfect your hands.
Okay. And we may go 5 minutes over if that's okay with you, if you don't mind.
It's fine for me. Yeah, it's fine for me, of course.
So as long as the webinar police don't step in, we'll be okay. One of our docs asked the question, he would like practical information regarding testing for doctors in the outpatient setting. You know, what's the process that you recommend? And we have had a lot of discussion amongst ourselves. The docs that are our partners in particular have had several calls internally. And, you know, obviously getting the testing equipment is one thing. In order to get the swabs has been very difficult. But what do you recommend as a protocol, as a mechanism for obtaining the swabs, and then and testing certainly, and maybe decision-making around testing, you know, who to test, who not to test, how to prioritize.
Right, and then what to do if they're positive. So yes, there's quite a bit. So let's start with just supplies for testing. So if you know, I think that your best resource anywhere is your local health department. So with this whole epidemic, it's the local health department that is really at the front lines trying to, you know, triage cases, trying to figure out who's on quarantine and trying to see who needs, you know, supplies. So the testing is a nasopharyngeal swab, which needs to be placed in viral transport media. and then it is refrigerated until it is shipped to the laboratory that will do your testing. But which laboratory it is something that usually your local health department will know. In New York, we had our New York State lab involved, but now it has opened up to commercial testing. BioReference is doing it. Quest, LabCorp are doing it. So you just need the viral transport media. And if you're using a LabCorp or a Quest, you can speak with them about supplies, I would imagine, as well, and your local health department. Now, in terms of who to test for healthcare workers, so there should, in any situation, healthcare worker or non-healthcare worker, there should be no testing of asymptomatic persons. There is no reason to test an asymptomatic person. And when it comes to symptomatic individuals, if someone has symptoms and they're a healthcare worker, we have to also test for the usual respiratory viruses. I always like to mention that I think when we're in an outbreak setting, it's easy, we all get a little bit monocular vision, myself included. You know, you're so concerned about not missing that outbreak case that you kind of forget about the other things that you would normally be thinking about all the time, right? And so it's important to always be, you know, continue to have your normal differential diagnosis. But if you have someone who's negative flu, negative for respiratory pathogens, has fever and cough, certainly in this day and age, COVID-19 is something that you want to consider testing, in particular in a healthcare worker. CDC has just issued revised guidance in terms of what happens when a healthcare worker is positive. So first of all, you have to have resolution of symptoms. And there's guidance about how long you have to be, at least 7 days from symptom onset, several days with no fever without the use of antipyretics. There is no requirement for repeat testing of healthcare workers. I want to show you a slide in a moment that indicates that when you're doing a PCR test, which is what we're doing here for detection of this virus, you have to remember that a PCR is not detecting live organism. It's solely detecting the presence of the RNA of the organism. And sometimes when we do PCR tests, we can get a positive. There might not even be a live organism there. The person may not be infectious. And in fact, if I just scroll down a minute, I think I have to scroll back up, sorry, to this slide. This is a complicated, colorful slide, but I want you to focus on the blue. This is the blue pieces of each line. These are 18 patients, and this is when the green is when they presented with symptoms. Dark green, they had fever. Light green, they just had cough without fever. But the blue is when they become asymptomatic. And the dots within the blue, red and green, are whether the PCR was still positive. And I think if you focus on the blue, you can see that some people continue to have virus detected. And this is of concern in terms of what do we do? Can the person go back to work? What can they do? And for health, and that may not be live virus. So for healthcare workers, there is now new guidance from CDC indicating that with certain parameters, there's no need for retesting and you certainly can return to work.
Yeah, we've seen some cases where people have been asymptomatic for quite a while but they're still testing positive. So that ties in certainly. And, you know, in terms of a practical protocol, you're in the office, patient calls you, they want to come in. Walk me through the process. Do you meet them in the lobby of the building? You know, do you leave a package for the doorman? What kind of protocol do you do in terms of having them swab? Do you have them swab themselves? Will they do that properly? Can most people do that? You know, how many times you've swabbed somebody and they sneeze right back at you or something. So how do you practically recommend handling that? What are you folks doing?
So I think, so let's start with the patient calls and says that they have fever and cough and they haven't been feeling well for 4 or 5 days and they really feel like they need to be seen, right? So it's a patient where the index of suspicion is relatively high. so what you can do is actually set up a station, right at the entrance to your office, like a hand hygiene station, which will have surgical face masks and capacity for hand hygiene. Ask the patient to disinfect their hands at this station and to put on a surgical face mask. And then to call that they have arrived, depending upon how you're set up, you might be able to see that they've arrived. And then you would have them come in and you would place them in a single room and close the door. I'm sorry, I should have said that before you greet them at the door, you would don your own personal protective equipment, which would be your own surgical face mask, gown, gloves, meet them, bring them to a room, and have them go in. And there you would take your history. We take the history as best we can through these masks, right? And examine the patient. And then while you have your personal protective equipment on, you would ask them to remove their mask, and you have these are these very flexible swabs that you insert through the nares and go back to the posterior pharynx the exact same way that we do a pertussis swab. Put it in. When you go all the way back, you're pulling nasopharyngeal cells. So you just go in, move it, around a bit, and then you pull it back in, insert it directly into the viral media, close that. Everything should have been pre-labeled before the patient went in. You want to have yourself all set up so you don't need to be wasting any unnecessary time or touching things that you don't need to touch. And then whenever you're done with the patient, you can have them leave and with their mask on until they exit the office. And you would then remove, when you're ready to exit the room, you remove all your personal protective equipment, disinfect your hands, and send your test off. We do not do patient self-testing. It's not comfortable to do to have a nasopharyngeal swab performed, and I don't think it's the kind of test that lends itself to self-testing.
Let's talk for a minute as we wrap things up here about treatment options, what you're seeing that's giving you some hope and promise, and then also, what about immunity? What's happening, and what are we thinking about patients becoming immune, and then I guess really as a population developing immunity? I know it's a pretty packed question for the last few minutes here, but maybe if you can give us a quick overview on the treatment and then immunity and how that seems to be tying together. And then I do one more last question on a couple of myths that I think we should debunk real quickly. So.
Sure. So I'm sorry, I should have pulled this. It's in another presentation, but there's a lovely graphic of where things work. So, so there are several drugs that are being looked at. So I want to say, first of all, that we learned from the SARS and Mideastern coronavirus experience that steroids are not a good idea. From that same experience, the HIV medication, Kaletra, which is lopinavir and ritonavir, has been used for these novel coronaviruses and actually was quite beneficial in SARS and is also beneficial, as you can see in this slide, with Mideastern coronavirus. The reason Kaletra is effective is that Kaletra is a protease inhibitor, and by being a protease inhibitor, it inhibits the proteins from coating the organism, which is what it needs to actually get out of the cell and exit and infect another cell. And so this is actually a very important step for coronaviruses. And so protease inhibitors are being used. The other drugs are remdesivir. Remdesivir is being used in a trial at the University of Nebraska, where many of the U.S. citizens who came back from China are, who were sick. This is a broad-spectrum antiviral that works against a lot of the viruses that we're quite afraid of, like Ebola. It terminates RNA chain transcription, which is a necessary step for the virus to replicate. And it was used in Mideastern coronavirus and appeared to be beneficial and is now in trial in the United States and is available by compassionate use. Chloroquine and hydroxychloroquine are wonderful because here's an old drug that we can pull off the shelf. What chloroquine does is it actually increases the pH in the endosome, and it prevents viral fusion, which is really important. So, in theory, this could be really important as a prevention of infection after exposed even. So chloroquine is being used for some of these patients. It also interferes with the glycosylation of receptors that are needed for COVID-19. So it's actually got two steps where it could be beneficial. And as I already said, lopinavir/ritonavir blocks the protein processing. So what we do when we have a really, really sick patient in the ICU is usually chloroquine and lopinavir/ritonavir, and then depending upon how sick they are, they may go into compassionate use with remdesivir.
Thank you. And what about, immunity? What are you seeing? What's the early, investigation showing in terms of people developing immunity? And I guess there's some talk about plasma treatment. And what are your thoughts on that?
So regarding immunity, so with just regular coronaviruses, the viruses that cause the common cold, you have immunity, but it's transient. But you do have T cells that recognize the organism later on. So with these viruses, there is quite a bit of work being done on this to see, whether there will be some immunity developing. I don't have those slides with me, but I think it is promising for vaccine development. And then there are also blocking antibodies that are being looked at. And I didn't mention something that's important. So all these coronaviruses, SARS, as well as this novel coronavirus, COVID-19, they have, besides causing infection and replicating as an organism, they also have an inflammatory component. And with SARS, this was very clear. That's what led to the use of steroids in SARS, was that there was an inflammatory component, a cytokine storm that occurred. It's a little more complicated with COVID-19. There's both helper cells and suppressor cells getting activated. But IL-6 inhibitors and other anti-inflammatory and anti-cytokine agents are being looked at for this.
It ties into a little bit of a myth. There's some concern about using ibuprofen for treating symptoms of fever. There's a lot buzzing around that's a problem. Maybe you can debunk that.
I don't think we're ready to debunk it.
Okay.
So there is, so I thought it was a myth as well, but I think there is an article that I have not had a chance to pull in the British Medical Journal, and apparently there's a bit of history of this with SARS. And so, although this is not behaving like SARS in terms of its spread, SARS is its closest relative as an organism. And, so when we look at how is this feasible? It is my understanding that there was some information with respect to the receptors in the lungs and the effect of ibuprofen on that attachment. I believe that's the mechanism, but I have to look at the British Medical Journal article.
So in the interim, how would you recommend that our physicians, prescribe treatment for managing fever and the other symptoms, and certainly finding?
I would use Tylenol. Tylenol.
Okay. And so sort of trying to wrap things up, what's your gut? Where do you think we are? What do you think is the prognosis here, with how the $10 trillion question, right? But Not to put you on the spot too much, but I figured we'd get to the meat of the issue here.
Well, I think that an incredible amount has been done. I had the opportunity to be with a colleague of mine who's a microbiologist, and he spoke about vaccine development earlier today, as well as treatments and various options. And the amount that has been learned in terms of the sequencing and the similarity between other coronaviruses and the preserved areas that help us to understand both how this is attaching to receptors in the lungs as well as receptors in other parts of the body, and what may happen is really moving very quickly, and I think that's very encouraging. But I think we're in for the long haul for a bit. As Dr. Fauci always says, you have to wait for that curve to flatten a bit, and we are not, it doesn't look quite like it's moving that way just yet. It's going to take time. If the incubation period is 14 days, and it's probably not that long, but it can be out to 14 days, you have to wait a couple of incubation periods before you know which way something is going. Yeah. And then this is further complicated by the fact that testing was just recently unleashed, and so it's going to be very hard to know if we're moving in the right direction or the wrong direction when all of a sudden there's going to be a huge surge of results, and a certain percentage of those are going to be positive, and yet some of that may just be testing bias because of the much broader testing going on. So I think we have to plan for at least a couple of months. I don't know that we'll be able to do all of the distancing and as a society be able to maintain that. But I think, I don't think this is just going to suddenly go away in a couple of weeks.
Yep. It sounds like we've got to hunker down for a little bit, take it 2 weeks at a time, and keep assessing, and hopefully the models come into the right alignment over time. Well, I'm going to jump back on the video here just to say goodbye to everybody. And thank you again, Dr. Montecalvo. We really appreciate the extra time you've given us, and I want to thank everybody for joining us tonight. I'll try to make as much information available as I can. Certainly, if we can make the slides available to our clinicians as well, that would be great. And this will be recorded if folks want to listen to it again. I want to thank all the members, Castle Conley patient members, for joining us. And as you know, we're here to help, and we're here to help our partner physicians as well as all of our members. And if there's anything we can do, don't hesitate to reach out. And thank you again, Dr. Montecalvo.
You're very welcome. My pleasure. Thank you.
Thanks so much.